Welcome everyone to today's webinar. I'm Mackenzie Bean, Managing Editor with Becker's Healthcare. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. To begin, let's introduce our presenters. Dr. David Presser joined the emergency department at Torrance Memorial Medical Center in 2005. Since then, he has championed local initiatives to address the opioid epidemic, co-authoring TMMC's Safe Pain Medicine Prescribing Guidelines for non-cancer pain in the ED that became a model for hospital-wide guidelines. Dr. Presser is interested in the challenge of coordinating care for complex patients with high rates of repeat ED visits. When TMMC adopted the ED software platform in 2008, Dr. Presser served as the first chairman of a multidisciplinary committee using this tool to create safe and appropriate care plans for patients with high rates of ED utilization while also addressing patient threats of workplace violence. Dr. Gina Solmeyer joined the staff at Torrance Memorial Medical Center in 2001. She quickly found an interest in informatics, assisting in the development and implementation of the EHR in 2006 and transitioning the emergency department from paper documentation to electronic documentation in 2013. With the affiliation between Torrance Medical Center, Torrance Memorial, and Cedars-Sinai Health Systems in 2008, the need for an integrated hospital-wide informatics program became more apparent, and she stepped into the role of a physician advocate to clinical informatics, representing the liaison between the medical staff and the clinical informatics and applications departments, clinical quality, and information systems. In 2019, she helped integrate the electronic health system between TMMC and Torrance Memorial Physician Network, bringing 110 outpatient physicians into one network. Continuing as Chief of Emergency Medicine since 2017, her goal is to continually reach for seamless communication between all departments of the health system. At this time, I am pleased to turn the floor over to our presenter, Dr. Presser.
So this is David Presser. I have been nominated by Gina to do the bulk of the speaking, but I can assure you, much like the Magic Act Penn and Teller, without a partner like Gina, this act would be a flop. So with that in mind, let me dive in. And we've named our talk Becoming Problem Solvers. And that's because what began as a committee with a very sort of narrow scope of focus has expanded over time, and we hope to share that story with you. Let's start with an overview of what we'll be talking about. We're going to discuss a little bit what collective medical is. Collective medical is a tool. You'll note that I introduced myself as the chair of the EDI or EDIE committee. We'll clarify that during this talk, the terms EDIE or EDI and collective medical will be used interchangeably, much like Kleenex and tissue, and I'll explain that in just a moment. We'll sort of get a bird's eye view of Torrance Memorial Medical Center, our facility, so that you can see what similarities or differences may or may not make our strategies applicable at your particular institution. We'll talk about the evolution of collective and how we've sort of learned to use and adopt the tool at our hospital. We'll talk about how we tried to create an unfair advantage at the outset of the formation of our committee, how we sustained momentum after the initial excitement had worn off, and then how we were able to pivot to address workplace violence threats that emerged over time unexpectedly. Finally, we'll talk about how we decide which patients referred to the committee get a care plan, and how we've been able to assess the impact thus far. So let's start by discussing collective medical. The collective medical is the name of the parent company as well as the platform, a software platform that was originally named the ED Information Exchange, commonly referred to as EDI or EDIE. This was born out of a need in the emergency department. I might mess this up slightly, but the sort of origin story of the company is that a very tech-savvy undergrad came home where his mom, who worked in an emergency department in a senior level capacity, he found her either typing out in an Excel spreadsheet or writing out longhand notes on her emergency department's frequent utilizers. And he tried to come up with a technological solution that would help her keep track of this. This was the way that she kept track of who had gotten a set number of CPs, who had recently visited hospitals in the area and received controlled prescriptions so that they would better eliminate information asymmetry. Well, out of this interaction between mother and son, a company and a very useful tool was born. Collective Medical, also known as EDI colloquially to those of us who were early adopters, is a platform that is licensed to hospitals in order to provide real-time notifications for patients based on very specific customized criteria. So the idea is if certain criteria are hit, and I'll give you examples of those criteria, they might be having visited greater than 3 emergency departments, distinct emergency departments over a 3-month period. They might be a patient who has had more than 5 emergency department visits over a 12-month period, regardless of whether they were the same or different sites. They might be multiple cures-based criteria. Cures is the California version of the PDMP, the Prescription Drug Monitoring Program, that individual states set up. The idea here is a way to monitor who uses controlled substances or has received prescriptions for them. So examples of cures-based criteria that an institution might enact would be things like patient has a prescription for a fentanyl patch, a patient with a prescription for Suboxone, a patient who has been prescribed both benzodiazepines and opiates simultaneously. These would all be sort of high-risk criteria that you could choose at your institution. Patients with existing care plans, whether they're designed by your hospital or another, might trigger a notification. And finally, patients with security events, think physical or verbally aggressive patients. So the way that real-time notifications show up, you actually get a collective notification. This is an example of how they appear in our database, where it will let you know the date and time, the criteria that were met by the patient that triggered the notification, whether or not they've had any security or safety events, and then the specific care guidelines, or the care plan as we'll refer to it, if there's any existing one. Finally, the nice thing about the collective tool is that it will actually do a cures query for you and bring up the past 12 months worth of controlled substance data. So this does use one of the ED group's members' privileges to sort of query cures and pull that information and push it to you in real time. A notification, and I want to make a distinction, a notification is different than a care plan. A notification just tells you that the patient triggered an alert. A care plan is a plan that a committee has formally created to address that patient's special needs. Not everyone with a notification will have a care plan. But for notifications, they're real time, they're sent to the provider at the point of care. They integrate quite nicely with our physician and physician assistant workflow because you find a notification immediately visible on the track board where you keep track of your patients. And then collective notifications, thanks to Gina's hard work with our information technology department, are located exactly where most providers would look to find notes with a filter to exclusively look at those. It helps you localize very actionable care plans, and it helps to facilitate coordination. This is what a real-time patient notification looks like. This is what our ED tracking port looks like under the LaunchPoint product. And I'll draw your attention to the right where there are blue, pink, and gray vertical columns. You'll notice that there are 2 pink columns, and next to each of those, just to the right of them, it says EDI Alert. And so that would be what a real-time push notification would look like. At the time you sign up for a patient, or even before the patient has been signed up for, you can tell who's got that notification. How does this work? Basically, I'll give you sort of the thumbnail sketch. The patient registers. The data is sent from the hospital's platform to Collective's platform, which is in the cloud, and Collective screens the data at registration against any criteria of the type that we just discussed. Then there's a real-time push notification sent to the provider at the point of care. This is nice because it does not require a separate screen to be opened on the computer, a separate log on as required by cures. password and possible two-step verification. It sort of helps to cure that problem of death by 1,000 clicks. And I'll give an opportunity now. Gina, do you want to elaborate on the technical explanation of what happens?
I think it's important to note that this does not satisfy the requirement for searching a prescription drug monitoring program by an individual physician. It is notification only, but as most emergency departments are exempt from utilizing prescription drug monitoring, it satisfies our purpose. The technical explanation, there's a very long version and there's a very short version, but essentially we brought together a team of system analysts, clinical informatics, clinical applications analysts, core integration architects, and physician champions working with Collective Medical to build the technical connections that develop this program. And now it works seamlessly within our electronic health record.
Okay. So moving on, this is what it would look like. After you get that push notification to the tracking board, you would go to the document section on the left, open up a filter for EDI, which you can see in the top bar there, and that would give you all of the EDIE alerts that this patient is triggered. Clicking on any individual one would get you then that summary page, the notification page that we saw earlier. So
there is also a direct link from the tracking shell to view the EDI alert without going into the patient's chart.
Thank you for clarifying that. So why choose this model for collaborative care and use this tool? The tool basically eliminates information asymmetry between provider and patient. So this is not just for patients with substance use disorders. It might be finding out if the number of CT scans or ionizing radiation studies that a patient has received, which would be valuable if you're evaluating a young female patient with an exacerbation of chronic abdominal pain, to know that that might actually change your management at the point of care. It also helps us to identify very vulnerable high-risk patients whose needs are not being met in our fractured healthcare system. These are the folks that need our help the most, and these are probably the folks where we need to pour in resources to try to address their needs. Not just from a financial perspective, but to make sure that they're getting both safe and appropriate care. So the question is, how do you successfully take this tool and implement it in your health system? Well, the way you can start is by figuring out what kind of an institution you have. Let me tell you a little bit about Torrance Memorial Medical Center. We're a community hospital, a not-for-profit hospital. We have 533 beds. We're a comprehensive stroke center, meaning that acute strokes are preferentially routed to our emergency department, where in conjunction with a specific stroke neurologist on call 24/7 through Cedars-Sinai telestroke services, we decide whether or not a patient's a candidate for TPA. If they either don't respond to TPA or present outside the window for lytic therapy, we do have interventional neuroradiology that can go in with a catheter and pull out clots from large vessel occlusions in the brain. We're also a STEMI receiving center with a very active cath lab program. We're a paramedic base station helping to direct paramedic traffic, including paramedic traffic from nearby Catalina Island off the coast of Southern California. Our ED volume by the end of this month is estimated to reach 90,000. That's been growing steadily since I joined in 2005, and is probably, I think we were about 60,000 when I joined in 2005, so that number has climbed drastically in that time. And that's a big number for an emergency department that functions with 46 beds and 10 chairs. Part of the reason that we're able to function at a high level of efficiency is because we implemented a pod system. I'm just going to take a quick minute to describe what that is. We realized that many of our providers had this sort of perception that there was an invisible miasma separating patients who were physically in the emergency department from those in the waiting room. And when we looked at our metrics, this was something that we wanted to address because patients in the waiting room were basically not getting care until they were physically brought back. Through a lean type program, we brought together doctors, nurses, techs, administration, basically anyone who might be involved in workflow, including environmental services, and designed a pod system where a single physician in conjunction with a nursing team captain, 2 nurses, and a tech, owns a specific geographic area of the emergency department and is assigned patients in the waiting room. And once that team is responsible for those patients outside of their geographic area, particularly at times of high volume or boarding, it made a big difference in bringing back those patients for quick screening exams into designated screening areas, getting rate-limiting steps like laboratory studies or imaging studies ordered, and speeding their care. So we make do for a small physical department with a large volume by implementing that. Let's talk about the evolution of collective medical at Torrance Memorial. In December 2014, a group of physicians within our group who were pretty passionate about trying to help address the opioid epidemic drafted a safe prescribing guideline for the emergency department. As part of that effort, we were in communication with statewide, local, and county emergency medicine leaders to try to adopt best practices that were consistent with what was being supported at larger levels. Those folks that we were in communication with then referred us, the CEO at Collective Medical, and we've been screening various different tools that could pull in data or try to share data in local networks. Collective was by far the most advanced of the ones that we looked at. In April 2015, I had a coffee with the CEO at Collective Medical, was very impressed by what they offered, and by bringing that back to one of our group meetings, we had our emergency department directors begin to lobby hospital administration for a budget to adopt the EDI tool. You'll note that it was not until November of 2017 that EDI was approved for the following year's budget. So from 2014 to 2018, that's a 4-year lag to get that budgeted. But the nice thing about that is, I think the lesson that I take from that is if you can play the long game, by the time you get the tool you're looking for, you will be in a great position to execute. So now that we finally got this tool 4 years in the asking, we were looking to give ourselves the best odds of success possible. One of the things that we did was we were put in touch through Collective with a big SIB, a hospital close to our geographic area that was already up and running with an active program using the EDI software. Additionally, after speaking with the chair of that particular group and realizing that that was a significant amount of work and a significant amount of time that would be spent to get, not just to get it up and running, but as more care plans were designed to maintain this program, we went back to our ED group and we decided to fund the position that would take care of this program with an administrative stipend. There's a big difference between a physician champion who feels that they're being reimbursed for their time and sort of takes ownership versus a voluntary position where there's not necessarily that same level of responsibility and accountability. Because we were lucky to have several physician champions that were willing to own the program and work with it, that was a big secret to sort of having that success. Finally, EDI care plans or collective medical care plans can be designed in a number of ways depending on the institution. At some institutions, case managers create all of the care plans exclusively. At some, any clinical physician can be given privileges to create a care plan. What we decided was best and most appropriate for our institution was to have a single physician enter all the care plans. The idea behind this being that by having one person enter, we would be able to ensure quality control, make sure that every care plan was concise, actionable, and either ED specific or for patients who were being admitted could be hospitalist specific for the transition to the inpatient wards. Additionally, we sort of created over time a series of a la carte plans where we would pick and choose from some standard treatment options or care plan options and assign those to patients. We had outreach to cultivate a broad referral base, which I'll discuss a little more in detail in a moment. We tried to get representation of stakeholders with specific expertise. So because many of the patients we saw in our committee were chronic pain patients, we are fortunate to have a pain management physician who does a significant number of inpatient consultations and whose office is nearby. We invited him early on to participate in our committee. Another example would be our sickle cell disease patients. We're fortunate to have a case manager who recently obtained her doctorate in public health with an emphasis in sickle cell disease. And so we're able to seek out expertise where we need it and screen any plans we have with patients with those special needs with the appropriate expert. Finally, we've been providing individual feedback to providers who deviate from the care plan, and I'll talk more about that in a minute. So a sample care plan in that care guidelines section from the earlier slide might read as follows. There will be a specific bullet points for the emergency provider as well as for the hospitalist, directing them towards a plan that's been agreed to. If this is something that's been discussed with a specific pain management provider, their name might be cited and the date and, that plan was agreed to. The idea is that this is sort of something that helps us all give more consistent care across the spectrum of hospital-based care. Our program got off to a strong start. We started with a summer site visit where we had approximately a dozen people from our fledgling committee go to a sister hospital that was already using the ED software, and our formal committee, which we creatively nicknamed the TMMC ED Committee, formed in September of 2018. At that initial committee meeting, we had representation from physicians, from nurses, social workers, case managers. We had floor leads who were very interested in their most difficult patients and how we could sort of set the tone for their admission, and we had administration represented. We found that the care plans that we were designing were largely for patients with chronic pain or substance use disorders. There were a significant number designed for patients with mental health disorders, specifically those prone to acute psychosis. We found that we began to become a source of behavioral contracts for disruptive patients. And that was very empowering because the ED oftentimes can have sort of a defeatist approach that we have to accept behaviors that would not be acceptable at the dinner table where our parents raised us. And by just changing that expectation and empowering our staff to let us know when people deviated from that acceptable social standard, we were able to actually improve the level of behavior from a number of historically difficult patients. Finally, we settled it around a level of 10 to 12 cases referred to the committee per month. To give you perspective, the sister hospital that we first sat in with had about 4 to 5 cases per month. So we were a pretty brisk and busy group at the outset. Our early outreach involved going to hospitalist meetings to ensure that our care plans were continued on the inpatient wards. Initially, there was a handoff, basically a warm handoff where emergency physicians were telling the hospitalist, hey, this patient has a care plan and this is what it says. We invited hospitalists and pain management physicians to serve on our committee to try to get their involvement and buy-in at the outset. And there was often offline PCP and specialist communication to collaborate on a shared plan. So one example that comes to mind would be a young woman with prior surgery and chronic abdominal pain, where I would call after our discussion in committee and speak with the primary care physician, the gastroenterologist, the bariatric surgeon, to agree on a single specialist prescribing controlled substances and inform them all of the plan that we had adopted for the emergency department to make sure that they were comfortable with that plan. Also to establish criteria for when imaging might be indicated to try to reduce sort of that ED inclination to image abdominal pain that's undifferentiated. There were also occasional phone calls to insurance directors and even to a captain in the fire department for one particular chronic inebriate patient who was calling 911 about every other day for a period of time. As our outreach matured, we started to find allies within the community that were beyond our initial network. So the Torrance Police Department in our area, which frequently brings patients to our attention, has a mental health evaluation team composed of a staff psychologist and several officers that go out when officers find themselves interacting with someone who is likely to have significant psychiatric illness. That's a great initiative on the part of the police department, and we actually had their staff psychologist and police captain sit in on one of our meetings and give us advice on how to handle some of these patients who are big challenges, both from a behavioral standpoint, but also from a mental health standpoint. We found that one of the unintended consequences of establishing care plans as our program matured was that sometimes patients fielded complaints, and those complaints arrived in the office of a patient advocate. Well, after a certain number of interactions, we invited that advocate to join our committee so that she could witness firsthand our approach to caring for these patients. and ensure that these were not arbitrary decisions, but rather thoughtful, well-designed decisions as we made them. We were able to serve as a big SIB for another emerging program at nearby Martin Luther King Hospital. Finally, another victory was that care plans that were initially visible only within the emergency department are now accessible to all inpatient physicians. And that platform has expanded. So we design plans that not only handle the emergency department treatment, but also extend to inpatient care and are visible to inpatient care providers. As a result of that, we got a nice reputation because anytime that doctors and nurses are working together and really excited about a project that they're doing, it naturally attracts positive attention. So we became known as the little committee that could. Our emergency nurses felt very empowered, and they developed the equivalent of what I'd call a secret watcher program. I use that term, it's derived from an infection control officer in the hospital that arranges basically surreptitious observations of whether or not our staff in the emergency department and in other areas are foaming in with disinfectant prior to entering a patient room. And what we found was that our nurses were really excited backers of the ED care plans that we designed. So whenever a clinician deviated from that care plan, they let us know. And we were able to subsequently talk to those clinicians in a non-threatening manner, saying, look, this is not a gotcha, but we want to understand how our care plan can be more robust and what would make it useful. In other words, what would help you both access and utilize and feel a sense of buying in and adhering to that program going forward, that care plan going forward. Finally, our ED nurses are a great source of referrals for patients who require behavioral contracts. Those behavioral challenges that are very intensive and exhausting for nursing, that's exactly who we want to hear about and do something about. Additionally, I think it's a nice reflection of our plan that we have been working well, and half of our referrals come from our social workers. We started over time to develop an unsolicited referral pipeline from an accountable care organization and from local HMO directors who were excited about the work we were doing and wanted to see if it might help also reduce readmissions over time. Our hospitalists began to refer troubling repeat admissions to the hospital to see what we could do to help provide appropriate care and see if we could transition certain patients that fell through the cracks more to the outpatient setting. And I like to think that sort of the ultimate forms of medical staff recognition were twofold. We knew we had made it as a committee when first off we got official recognition from the medical staff office as a subcommittee of the emergency department. That was valuable because it provided us medical legal protection. Our discussions in committee are considered peer review and are not discoverable. But similarly exciting, we got food at our meetings, which is a huge victory if anyone has tried to do that before. I also want to just make a quick note of the fact that our outstanding ED nursing director is going to be making a poster presentation. This says 2019, it's actually in 2020 at a big nursing leadership conference in our state. And I think that that's important to highlight because we're really lucky that we have amazing team members from all areas. This is a shared credit sort of committee. So we want a win for our committee to be a gold star on each committee member's CV. And we've been lucky that we've had such buy-in and such support. We want to pay that forward. We want people to be able to present the work that we're doing to help their careers because it's important work and it needs to be promoted. This sort of work needs to be advanced both in nursing and social work and all sorts of fora. So this committee had established this track record when we had to pivot unexpectedly to something that none of us had really given a lot of thought to, even though we were all acutely aware of it in the back of our minds. 1 month after our committee formed in October 2018, we were referred a patient who was a paranoid schizophrenic, choosing to be off psychiatric medication, who had multiple visits per week relating to chronic pain where the patient was coming to the ED requesting narcotic refills. We created a care plan that included no controlled substances during ED evaluation in the absence of a new emergent condition with pain management and PCP referral. And that seemed to be going okay until January 2019, when in the span of about 9 days during 2 ED visits, the patient, while alone with 2 female providers, specifically mentioned that he had access to weapons in a very thinly veiled attempt to intimidate those providers into providing narcotics. Well, because we already had this team in place, we tried to put together a response as quickly as possible. One of our crackerjack social workers verified via police department contact that this patient had indeed had a firearms cache removed from his home. Our security director was invited to come to the ED Committee meeting and was able to perform a background check to show that there was no prior criminal history. From that time onward, the security director has been a crucial member of our committee. We contacted Collective Medical and spoke to their support team to ask what tools that we might not be using yet were available in a crisis situation like this where we needed to know the second the patient hit our door. And finally, we explored legal options. Turns out there's a very high threshold, at least where we practice, for enacting a restraining order that prevents a patient from seeking emergency care. And so our legal team advised us that we could not really prevent this patient from coming, and they were entitled to a medical screening exam as often as they thought they had an emergency by prudent layperson standards. So we would best be able to address the situation by devising an appropriate protocol. Since that time also going forward, our legal team has been a very vital member of our ED committee. So we developed a security protocol for starters. We found out that Collective Medical was able to send an automated text message and or phone call to the Director of Security via the ED platform at the time of registration. The director couldn't see what that text was about, but they were just notified that there was an alert. They would log into the system, identify the patient that was a workplace violence threat, and immediately call the security staff stationed in the ED. The security officer would then guide the patient to a designated evaluation area away from the other patients in the waiting room, would warn them to ensure they had no weapons on their person, and remained with the patient throughout their ED visit. At the same time and in parallel that this was happening, our lead nurses were trained to identify patients who were flagged as threats of workplace violence. Because there was a fairly small number of these, it was not hard to get both the night and day shift leads alerted. And the idea was that as soon as the lead recognized that name, they alerted the staff at the time of registration. The idea behind this redundant identification technique is that if there was a failure, let's say the lead was busy or the security department head for some reason did not get notified, there was a technical difficulty, having that backup would increase the likelihood of a successful alert. When these patients with workplace violence threats are admitted in cases that they are, there's an inpatient security management watchers program where we tend to admit them to the same areas to sort of have staff that are familiar with their needs and are adept at handling those needs. We also developed a medical protocol. We're lucky to have some exceptionally capable female physicians, so I don't want this to be misinterpreted. It wasn't that male physicians and nurses were used because of our heft or our particular abilities, but more because this specific patient had threatened female providers repeatedly and exclusively female providers. So a male nurse and physician would go to this expedited screening area separate from the other waiting room patients where security waited with the patient. We felt that based on prior ED visits, which revolved around an analgesia request, the patient was conducive to rapid evaluation and disposition, and speedy throughput was prioritized. If the patient required more complex evaluation, they were moved to a highly visible area with a security guard or a sitter at their bedside and a security escort off the premises if necessary. So how do we decide who gets a care plan? We have different groups of patients and categories that we try to sort of track them in. We look at utilization categories, which are a different subset. We've tried to derive useful metrics, given that we were a fairly new program at the time, in existence for about a year, to try and figure out whether or not we were having an impact. And then we tried to assess the impact, saying, were we successful in reducing utilization? And for those where we weren't successful, were there characteristics that might help predict who's going to fail just a care plan type intervention? in terms of our patients and categories, within the first 12 months of our existence, we had 89 patients with care plans. That's a far lower number than the number of patients we discussed in committee. Sometimes we'd be referred a patient who it turned out we did not feel required a care plan. A large number had substance use problems. These could include dependence on illicit substances, chronic pain syndrome under the management of a pain management physician or a PCP who consistently prescribed controlled substances for their pain, alcohol dependence, and then cannabis hyperemesis syndrome, which we're seeing a lot of with the decriminalization of cannabis in California. We also had a large number of psychiatrically fragile patients. Think of schizophrenic and bipolar patients, oftentimes homeless, but not always presenting an acute psychosis. As to medically fragile patients, I would have expected far more CHF and COPD patients than were necessarily referred to the committee. It turned out that most of our medically fragile patients were insulin-dependent diabetics with a concomitant substance use problem. As one of our physicians put it, Lasix abuse did not seem to be a major problem in our emergency care. And finally, we tried to have as a category convenience, meaning how many patients were coming to us because we were open and easier to book an appointment at than their primary care physicians. Turned out not a significant number. We also keep track of our homeless patients, in part because of recent state legislation, but in part just to see how we can best serve those patients. Collective has its own utilization terminology, which you can see here. I'm going to focus on the last four categories. 10 to 19 visits over 12 months is sort of a rising risk patient. 20 to 49 is a high utilizer. 50 to 99 ED visits in 12 months, super utilizer, and 100 plus visits in 12 months, extreme utilization. So when we looked at our patients with care plans, we had 26 rising risk patients, 22 high utilizers, 13 super utilizers, and 2 extreme utilizers. And it's important to note that just because you're in this category doesn't mean you come to our emergency department at that level. So 2 of our extreme utilizers, one of them does come to us probably about 150 days out of the year. The other one actually comes to us about 5 to 10 days out of the year, but goes to other emergency departments at a much higher rate. So just because someone is an extreme utilizer doesn't necessarily mean they need a care plan at your facility. Here's an example of one of our extreme utilizers over time. And what you'll see is that the light blue is all facilities. In this case, the dark gray is their visits to our emergency department. I want to just note that as you get to the right, the slope over time appears to be steady. It's not an exponential growth curve. In other words, these folks come and they repeatedly come at the same rate. They're very difficult to treat with just a care plan. Here's another example of that extreme utilizer that basically shows a fairly steady and high rate of use of both our emergency department and another nearby emergency department. So in deriving useful metrics and trying to come up with a plan for how we would care for these patients and see if we were making an impact, we decided to use visits per month both before and after the care plan. The idea behind this is if you've got a relatively new program, as we did, there was a lot of data before care plan implementation and very little after. So this is useful for a short-term assessment. It was also useful to help us identify non-responders to care plan interventions early on. Because a lot of this data requires very painstaking abstraction, we just arbitrarily on August 4th looked at the 71 patients as of that date that had care plans and tried to use that as an inaugural data set to see what effect were we having. We found that we had a median reduction in monthly visits of 52%. That's pretty impressive, and we were really pleased with that. But what was equally revealing was that 17 patients had an increased rate of monthly visits after implementation of a care plan. So here were patients who were not responding to our interventions identifying themselves. That was fascinating, and it was an important subset to look at. This is what a graph of our monthly visits after care plan looked like over time. And basically, you can see, if I can draw your attention to the 0% line horizontally, the bulk of those patients are below that line. But when we subtract the patients that had a reduction, this was the population that was fascinating to us because this was a high utilizer population that kept coming. we tried to get better characteristics of what those patients looked like. So when we looked at patients with increased characteristics in spite of the care plan, there were 17 total. We broke them down into different categories, 5 of them with straight up substance use disorders, 3 of them with substance use combined with psychiatrically fragile conditions, 4 of them were substance use with medically fragile conditions, 2 psychiatric and medical, think of for example, schizophrenic who also has type 2 diabetes that is not well controlled, and finally 1 patient with an isolated medically fragile condition. And for those of you who like Venn diagrams, that's a rough approximation of what that population looked like. When we look at the patients who had threats of workplace violence, and there were 2 of them at the time this data set was examined, basically we had 2 that specifically had security notifications with expedited medical screening exam protocols. Both of them turned out to be paranoid schizophrenics with opiate dependence. It's just a really challenging population. I'll show you a graph of their use over time. So I'm going to draw your attention here to the difference in the light blue use going from February to March. In the month of March, that patient exclusively used another emergency department and did not use our emergency department at all. That happened to be about 1 month after the patient was notified that we were putting together a care plan for them. Basically, this is what we call sort of a squeezing the balloon phenomenon, where we, by establishing a care plan, temporarily shunted that patient's visits to another department, but didn't significantly reduce them, and slowly saw them return back to levels that over time became as high as they'd been before, maybe slightly lower. Our second case, there was no impact really at all from the time we implemented care management plans. They just continued to come. So what kind of impact did we have? I think our impact was probably more felt by our staff and the other patients in the waiting room than necessarily in a manner of reduced visits. I think we all felt that we were safer as an emergency department for our providers, our staff, and our patients. We all had a lot of confidence in our proactive security alert protocol, but the bottom line take-home message is that schizophrenia with opiate dependence is simply unresponsive to intervention. I know we're running a little bit over time here. We're close to wrapping up. So how might we target non-responders? Right now, our committee's brainstorming what we might do, providing concierge-level access for these patients, basically allowing them to be able to call a provider or drop into a clinic anytime that suits their needs may be the next step, and we're working with different groups to see how that might be arranged. There's intensive case management for members of the Accountable Care Organization, where every time a patient visits the emergency department, a case manager is calling them to try to set up timely follow-up. Essentially, they're system navigators for these patients who don't seem to be able to navigate what can at times be a fractured system. We are lucky to have what's called our Care Coordination Center at Torrance Memorial, which is basically a place where patients who've been recently seen in the emergency department or discharged from the hospital, but who have excessively long waits to see their regular sources of care can come in and get the sort of timely follow-up that they need. Finally, for a large number of patients that are out of network, we have our case managers call their insurance case managers to make sure that the high utilizers who repeatedly come to our emergency department are on the radar of the case managers within their systems. In the pipeline, we have some exciting things that we're working on developing, including monthly reports of the highest utilizers, sort of our top 10 list for prior months, to see if we can focus on them or how we can course correct if we're not making progress. Trying to get more useful standardized data within and across institutions, things like the visits per month, and seeing how we compare to other hospitals in the area with similar populations. Reports by levels of utilization, extreme, super, and high utilizers in particular. And then reports by category, seeing if we're finding an unexpected increase in substance use, psychiatrically or medically fragile patients, and trying to partner with the appropriate community services that can provide care to those patients. Finally, we're hoping that just like those columns on the right-hand side of our tracking board popped up pink with an EDI alert, we'll be able to get a separate pop-up that notifies when either a security threat or a patient with an existing care plan registers. And with that, I will turn it over to questions.
Great. Well, thank you, Dr. Presser and Dr. Stellmeyer, for that great presentation. We'll now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we have time for. The first question is from an audience member who asks, do you notify all patients of their care plan creation?
So that's an excellent question. Typically, we notify patients of their care plan creation when it may affect their inpatient care or their care in our emergency department. So I'll give you an example. A patient who might come in with a chronic pain syndrome who we notice has had a recent significant uptick in their visits to the emergency department or their need for admissions for breakthrough pain. We do send those patients a letter. And the letter has evolved over time, but it essentially says, look, this recent increase in utilization has brought you to our attention. We are concerned about you, and we're concerned in a good way. We realize that you are falling through the cracks and something is not working in accessing your outpatient source of care. We are going to put together the resources of our committee to try to come up with a care plan that meets your unique needs. But in the interim, we really recommend we'll look at whether or not they have a primary care physician or a pain management physician on record. And we will say, we would really encourage you to contact your specialist or your primary care physician and come up with a breakthrough pain plan that meets your needs. Of course, we're always available to care for you in the emergency department, and anytime you have an emergency, we are open 24/7. We will never turn you away, but we want you to know that we are trying to address your needs with this multidisciplinary committee. That sometimes what we learned over time is when we initially sent those letters, some patients who already felt stigmatized because of their use of controlled substances responded by saying, gosh, the provider who treated me in such a way that I felt like I had done something wrong and they were telling me they had caught me in my nefarious plot to extract controlled substances, when really what I was trying to do was address my chronic pain. And so part of the issue was, I think, working with our providers to let them know this committee is not at all designed to catch truants and punish them for their sins. This is really designed to give patients thoughtful, safe care and not put them at risk, to make sure that the cure we're offering isn't worse than the disease that they're treating. So I think there was a messaging component to that, but generally patients with those sorts of care plans are notified. If there's a patient who might need resources, who we might say, hey, please call the pain management physician or the specialist because they've asked to be notified anytime their patient comes in, we wouldn't necessarily send a letter. But that's an excellent question. For patients where there's concern about controlled substance use with repeated presentations to the ER for conditions requiring that, yes, we do routinely send those patients letters.
Perfect. Thank you so much for elaborating on that, Dr. Presser. The next question is from an audience member who is seeking clarification on what consultant company provided support to help make this initiative successful.
So we used Collective Medical. I don't know if I'd call them a consultant company. We really worked with a motivated group of physicians, nurses, social workers, and case managers, sort of trying to figure out what would we like our program to look like. So I'd say the tool that we used was from Collective Medical, and we were grateful that it was a pretty powerful tool, and probably after having screened maybe 4 or 5 different tools, one that we thought met our needs most comprehensively and sort of solved more problems than most of them that were available. But we didn't use a specific consultant.
Perfect. Good to know. Thank you again. The next question is, are care plans shared with neighboring hospitals, and do they need to be part of the Collective Medical system?
Yes, so excellent question. If you're on the Collective Medical platform, you can immediately see if any other hospital has a care plan. So sometimes we'll find care plans that are in place from neighboring hospitals. Occasionally we get patients out of the Pacific Northwest, recently relocated from the Portland or Seattle areas, where a care plan is in place from a hospital in their former area. Those are visible, but you do need to be part of the Collective Medical system. It will not show up in your hospital electronic health record unless you are subscribing to the system. And so as that network hits critical mass, and I'd say that it has definitely done that in California and in the Pacific Northwest, as more hospitals sign on, there's more useful information available.
Perfect. Thank you again, Dr. Presser. The next audience member writes, we are challenged by a shortage of primary care providers in our community, and therefore our ED sees a high number of non-urgent or non-emergent patients. Do you see EDI as a tool to address our challenges?
I think that's an excellent question. Part of that depends on the resources available in your community. So for example, when we see an uptick in homeless patients presenting to the emergency department, oftentimes it's because they want a dry place to sleep and a warm meal. And what we see that as for us is kind of okay, how do we partner with the local homeless resources in the area? That's something where our social workers will kick into place. They also have basically a sheet that we can hand out to patients. It's now actually automated. We can give them at the time of discharge referral to a low-cost or county resources in their area. So I don't think that this is a one-size-fits-all solution to that, but I do think that it's helpful in tracking patients who are coming through. Like we talked about, that convenience category, which hasn't been a problem in our suburban area quite yet. If you find that a large number of your patients would be patients who visit the ED for convenience or coming to urgent or coming with non-emergent problems, that would be more of a trigger to touch base with your community partners rather than necessarily a solution to the problem.
I think it does help in a way. I think it does help in a way if it develops a consistency. Even if the emergency department is one piece of their care, by bringing in other resources that the patient may not generally find available and developing a consistent approach to caring for these patients each time they come is an important part of EDI.
Definitely. Thanks for weighing in there, Dr. Selmeyer. The next audience member is asking, how does EDI interface with your EMR, and what is your EMR platform?
I think I can take that. Our EMR platform is Cerner, and has been for many years. And when we were first implementing EDI, we worked with our IT department, who are all highly trained in Cerner, got some information from Cerner itself, and worked with Collective Medical in order to develop the technical link between the two programs. But Collective Medical is well-versed with many EHRs, and they were very helpful in utilizing Cerner as part of our implementation.
Perfect. Thank you for those insights. The next question is, what were the top 3 obstacles in facilitating integration of EDI with the hospital EHR?
I think that, as you could see initially in our slide, our number one obstacle was negotiating the budget and the contract. Things go slowly in large hospitals, as you know, and getting all the pieces together to start the program, have the appropriate contract, have the appropriate budget, and get into a budget year took longer than anything else. The second step was then the technical implementation that required bringing together clinical informatics, our clinical applications, system analysts, core integration architects, our physician champions, and ultimately our end users in order to develop the program to make it what we foresaw it doing. And then the last obstacle was adoption by our end users and getting the word out that what EDI was. And for probably close to a year, you would use the phrase EDI around the hospital, and people would look at you like they didn't know what you were talking about. But now we've gotten to the point where our committee has just exploded. It's been so useful that it has now stepped outside of the emergency department. It's initiated in the emergency department, but just to summarize who's on our committee, not only ED physicians, social workers, case managers, pain management physicians, psychiatrists from the local area, security, nursing administration, emergency department nursing, inpatient nursing, representatives from medical staff, hospitalists, including our 2 local large HMOs who do the majority of admissions at our hospital, members from our legal team, police, fire departments, therapists, patient advocates. You can see that almost all of those people are outside of the emergency department.
We actually have another question here about the committee as well. This audience member is asking, how often does your committee meet and what determines a case presentation at the committee?
Great questions. We meet monthly, and I think it takes about that long to sort of gather critical mass and also to do some information gathering about the patient. So in terms of what determines a case presentation, at this time it's exclusively through referrals. When someone says, hey, I took care of this patient and I think they'd be ideal for the committee, those tend to pour into me from emergency physicians, nurses, and social workers, as well as from hospitals via email over the course of the month. Each one of those patients I will look at their last recent hospitalization and discharge if that's pertinent, or their last, let's say, 4 or 5 emergency department visits and the dictations and summaries on their care to try to get to the root of what's going on. In some cases, I'll reach out to their primary care physician when it's appropriate, or their pain management specialist saying, hey, did you know that this patient has had these visits to the ED? Since, of course, they all happen at 3 a.m. on a Saturday night, when oftentimes specialists aren't contacted. So that anyone that's referred will be presented. Oftentimes, we'll decide that there's not very much to do. We had, for example, a case of a patient who is on dialysis but fails to establish a nephrologist and fails to show up at dialysis appointments and was repeatedly showing up in the emergency department. There's not a great deal that we can do about that. We might put in notes, or we might call family members to say, you know, how can we help plug this patient in? But with some psychiatric comorbidities that prevents that from happening, we're limited, and that patient, even though there's vigorous discussion, may not get a case or a care plan, but they will be presented at the committee. And these monthly meetings are vigorous meetings. Like Gina was saying, while not all of those people make every meeting, they're pretty well attended.
Wonderful. This next question focuses on the care plan, and it says, did you ever encounter any non-compliance among patients who are on a care plan?
Well, so there's non-compliance on the part of the patient and non-compliance on the part of the providers. And I'd say those are two separate issues. Non-compliance on the part of the patients all the time. And that, I think, is just due to the nature of their conditions. Folks continue habits, and it can be hard to change habits. And the sort of biggest issue in changing behavior is providing consistent responses that will change those habits. So for someone who expects to come into the emergency department and receive parenteral narcotics because they have in the past, finding that every provider says, look, we're happy to care for you and we're happy to offer you analgesia, but that's going to be non-narcotic analgesia. Once they've heard that a certain number of times, that can change behavior sometimes. In terms of, let's say, non-adherence rather than non-compliance among providers, like I mentioned earlier, we have a feedback loop, and the nurses are pretty keen on maintaining that feedback. So when people deviate from the plan, I reach out to them and I say, I'm not trying to bust you, but tell me what in the plan was not useful such that you deviated. Was there a particular unique condition in this presentation? Was it that you didn't know the plan existed or didn't know where to find it? That's how we try and address that.
Great, that makes sense. Thanks for explaining that, Dr. Presser. Looks like we have time for about one more question here. And this audience member is asking if you have ever used any other EHR systems such as Epic for an initiative like that.
Yes, Collecting Medical does work with Epic. Our initial big SIB hospital nearby that we went to for our training and learning about the ED program, they are on Epic. And I know there are several other hospitals in our area. Right now, there's about 45 emergency departments within a 20-mile radius of our hospital that use Collective Medical, and many of those people are in Epic and other EHRs as well.
Great, that's helpful for our audience to know, so thank you. That is all the time that we have left for today. I want to thank Dr. Presser and Dr. Solmeyer for their excellent presentation and Collective Medical for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.